It really is quite salutary, isn't it, to think how much of the castle of biomedicine is actually built on sand. Yeah, I'd forgotten that it was the love word. I actually said to someone just before this meeting started that I wasn't going to risk talking about healing, which involves concepts such as love, at this meeting, because I thought placebo was difficult enough for orthopedic surgeons, that healing was perhaps impossible. But I will tell you a story. This is off script. I'm going to tell you a story about my own osteoarthritic knee. It's a little tiresome that a man who has spent a lot of his career researching osteoarthritis develops it himself in his knees. And I've got grade 4 radiographic changes in both of my knees. And one of them hurts quite a lot sometimes, and the other one never does. That's quite interesting, but a totally different subject. And one of them got really quite painful a few years ago, and I was thinking, oh, this is bad. And I went to one of my daughters for Christmas, and I couldn't get up and down her stairs at her home. She's a doctor, she's a paediatrician. She said to me, for goodness sake, Dad, go and get your knee joint replaced so that you can walk properly. So I said, yes, Claire, maybe. And I went to my local knee surgeon and I said, this is hurting quite a lot. And he looked at it and he looked at the x-ray. He said, it needs replacing. I'll do it for you anytime at all, Paul. Just tell me when. And I thanked him. I said, I'm actually a bit busy at the moment, but yeah, I'll come back to you. Thank you. And I was just starting to investigate healing at the time, and I went to interview a healer in her home, and she said to me, you know, you can't really understand healing unless you experience it. Have you got a problem that needs healing? And I said, well, I've got a bad knee. Now, I'm an osteoarthritis doctor. I thought the chances of a healer being able to sort my knee out were negligible. So anyway, she said, well, I'll have a go. So she put her hands on my knee, and she sort of disappeared from the room in a strange way that people do with these practices. And she came back after a while, and she said, it's a very bad knee. I'm making some progress. I'll spend a bit more time, but it's tiring. I'll just have a little bit more of a go. And a repeat, she put her hands on my knee, she disappeared from the room, and a few minutes later she returned, looking exhausted and drained, and she said, it's a lot better, it's not perfect, it's a lot better now, you'll be a lot better. Now, I felt nothing, I was very sceptical. That's about 3 years ago, it's been a lot better, and I haven't had a joint replacement. Now, maybe that's healing, maybe that's placebo. That lady did it with love. I went back to my daughter a few months later, and I was getting up and down her stairs just fine, and she didn't notice that. But then, as English people do, we went off to walk to the pub, and she suddenly turned around and she said, you're walking properly. You must have had your knee replaced without telling me. I said, no, Claire, I haven't had it replaced, I've had it healed. Yes. So, she's a standard doctor, paediatrician. She looked at me, disbelieving, and then her face changed a little bit, and she said, you're serious, aren't you? I said, yes. She said, have you had it re-x-rayed to see if the x-ray's gone back to normal? I said, no, I haven't done that. And she said, well, if you have it re-x-rayed, and the x-ray's normal, we're all buggered, aren't we? She's not very well brought up, hence the bad language, but that illustrates it's very, very scary. This whole thing is very scary. I mean, I haven't had it x-rayed, obviously, but if things like love and caring and placebo can make us better from pathology, that's very scary. Just as scary as what Teppo's just told you, which is absolutely bang on the money, that a large amount of what we do and what we believe in doesn't actually work. Okay, I'm going to go back onto script now. So, briefly, how to enhance placebo effects and how to avoid nocebo effects. I would just take issue with Teppo over this being bad placebo. What his talk illustrates is that placebo works, and some of what we do that we think works doesn't. It's not bad placebo, that's good in a sense. So we should work with it, we should enhance it, and we should avoid nocebo effects. Now, you have learnt, your community has learnt over the last few years that some of the things you do, such as arthroscopic washouts and some spinal surgery, are useless. And it may be that a lot of the other operations you do are useless. But of course you don't operate on everybody you see, but you do treat everybody you see by being with them, by talking to them, by being a part of their illness experience, even if it's for a short time. So the last few minutes of this meeting are about how you can make people better or worse long before you even approach an operating theatre or a procedure, just by being with that person, just by being a clinician with someone else. Now, my conclusions from my first talk are shown here again, so just to remind you, placebo effects are a major component. Teppo is wrong, it's not 40%, it's 70%. Expectations and making new meaning are important mediators of it. The brain changes and patient-practitioner interactions are critical. But I didn't really talk much about the opposite effect of nocebo. But actually, bad is much more powerful than good. And if there's one thing I want you to remember from this bit of the afternoon, it is just exactly that, that bad is much more powerful than good. My PhD student Maddie and I published a paper with that title. Teppo said he liked good titles. I think this is a good one. Published that last year. Based on experiments with students and patients, we found that being invalidated by a researcher had a much more powerful negative effect than the benefits of being validated, about 5 times as big. And this fits with literature in education and elsewhere. We know that for every criticism you give a child at a school, for example, you have to compliment them 5 to 10 times to overcome the negative effect of a criticism. And I think we all know in our own lives that we are much more susceptible to being criticized than we are to being complimented. If someone says to me, which they may well do at the end of this afternoon, that was a terrible talk, that will affect me more than 5 of you saying that was a wonderful talk. I'll remember the person who thought it was a terrible talk. So bad is much more powerful than good, and this is absolutely true in our medical encounters as well as in the rest of life. So I also said earlier that what these phenomena teach us is that what's going on in these medical interventions is the important bit. And the challenge then is to understand and use these other factors other than our surgery or our pills to the benefit of our patients and make sure we don't do harm and avoid this very powerful negative nocebo effect that can be induced. And the other factors, which have already been touched on this afternoon, the other factors other than our pills, our surgery or whatever, revolve around beliefs, rituals, contexts and human interactions. So we'll just speak very briefly about each of these 4 beliefs, rituals, contexts and human interactions as the key factors that will make your patients better or worse, whatever else you do or don't do. And of course, one of the messages this afternoon is that it's often much better to do nothing than to do some sort of medical intervention. It's often better to do nothing than to do an operation or to give a pill. In the last stages of my clinical career, I gave up a few years ago because I don't really remember anything anymore. It happens when you get old. So I don't know what all these clever drugs are, and don't care actually either. But I did pride myself towards the end of my clinical career in getting through a clinic without ever prescribing a drug. And I think it is genuinely often better to do absolutely nothing, because you can use beliefs, rituals, contexts and human interactions for the benefit of the patient. So the beliefs, it does depend on what you and the patient believe, and Teppo talked about rituals and signs, and of course something like the stethoscope shown here is a very important power symbol and something that people believe in. And the rituals, of course, again, as Teppo talked about, your rituals are stunningly effective. Just the presence of this sort of thing, as Teppo again said, your hat on, your mask, all this stuff is hugely powerful without you having to do anything. And in the West, in the 21st century, I think we have a frighteningly strong, almost religious belief in the power of biomedical science and technology, and in these rituals, in our pills and potions, and our scalpels and prostheses. So, in a sense, we're on a winner to begin with. We don't have to do anything. Just put the mask and the hat on, wave the scalpel in the air, and you've made a very good start without actually doing anything else. The context and the space in which you do it is also very important. And this is a deeply under-researched area, I think. It's a well-known phenomenon in other disciplines, but it's not looked at much in medicine. I was involved in a recent study in Denmark in physiotherapy, where we did a well-conducted randomized controlled trial in which the randomization was to 2 different rooms in which physiotherapy for knee osteoarthritis took place. There was a nice room and a nasty room. This is a study done in Eva Roos's department in Aarhus by Linda Sandell. It's not Louise Sandell, I beg her pardon. It's not published yet, but they said they didn't mind if I mentioned it, and it has been presented at meetings. The trial showed clearly there was a big difference in outcomes between the 2 rooms. People got much better in the nasty room than in the nice room. Now, fortunately, we had done some nested qualitative research so we could investigate why that was. And the reason it would appear is that people felt comfortable and safe in the nasty room because that's what they thought a hospital physiotherapy department should be. That's where they expected. That was how it should be. That fitted with their beliefs, their understanding of the world. The nice room we put together, which had a beautiful view over a woodland, lovely soft colouring, great acoustics, they felt that was unnatural, that was wrong. They didn't feel right to them, they didn't feel safe. So it didn't work. So we got the wrong result, but the right result. The point is that where you do this, and the effect that it has on people, of where you sit when you consult with them, is actually very important. We don't know enough about this, but it is important, and it's something that I think we need to take note of. And then the most important bit of all, as I've already stressed, is the human interactions. The placebo and nocebo effects may be mediated by changes in the patient's brain, but they're initiated by the human interactions in context. And they're not just about what's said between patients, they're about this strange concept of the space between us. And I could have put the L word in that space, but I didn't. Sorry, Teppo. And interestingly, this depends on the giver as much as it does on the receiver. Some people, there's good evidence for this in these couple of references I've given at the bottom. If anyone's interested in any of this stuff, I'm happy to supply the references. Some people are much better at producing a placebo effect than others. And good intention seems to matter. So if you want your patient to get better, they're more likely to get better. Intentionality matters. I think actually that sort of messes up the whole of the evidence base of medicine. The reason I think that is that because we rely on all our trials and all our clever stuff, but if actually a huge confounder is whether the trialist wants the patient to get better or not, that's a confounder we never consider. We don't know how to measure it, we don't know what to do with it, and it may mess the whole thing up. Rather beautiful thought, actually. What really matters is whether you want your patient to get better, whether you love them. And we can inadvertently make things much worse for our patients than better, actually, even if we have good intentions. And that's a warning sign in this field as well. And again, this is more work from Maddie Greville-Harris. So you can induce a nocebo effect by mistake, even when you're trying to be helpful. And Maddie's work shows examples of this, one being, you say to a patient, well, don't worry, I can't find anything seriously wrong with you. And you're doing it with compassion, with empathy. But what the patient hears is, you think there's nothing wrong with me. So you think I'm a fraud. You think I'm making this pain up, don't you? That's what the patient may hear if you've got this wrong, if they're not in a safe place, if you're not in a safe place, if the context isn't right. And if they hear, you don't even believe me, they've been invalidated, they will get worse, their pain will get worse, and they won't come back. And so even with good intention, you can actually have the overpowering bad is more powerful than good phenomenon take over and mess everything up. So what do we know about all this? Well, my contention is that we know that there are 5 things that matter when we interact with our patients. We know that the rituals matter in relation to the beliefs and the trust of both parties, shamans and surgeons. We know that space and place matter as well, but we don't know enough about that. We know that this feeling safe, both doctor and patient, or therapist and patient, feeling safe or unsafe, makes a huge difference to our communication and outcomes. We know that we must avoid invalidating people, and we know that caring and good intentions matter and help people get better. But does that actually happen in most healthcare interactions in the 21st century? Well, I think not. Do you think either of these 2 people feels safe? Probably not. They're probably both scared stupid of the situation they've been put in, and they're acting parts rather badly by the look of it. And do you think he feels validated? Well, it doesn't look like it, does it? He looks very sceptical. And I suspect this is typically what happens, that we mess it up. How often in a standard medical consultation do both the doctor and the patient feel completely safe? We worry about errors, litigation, being sued. Patient always comes into our office frightened of what might happen. So what do we need to do? Well, I think it's moderately simple, but extremely difficult. I think the first thing that sorry, just checking the time. The first thing we need to do is prepare ourselves properly before we see a patient, I think, and make sure we're in a safe place ourselves and in the right mental space. I was first introduced to this idea relatively recently when I started working with some drama colleagues about communication in healthcare. And they invited me to take, this is another anecdote. Have I got time for an anecdote? It's quite a short anecdote. Hey, anecdotes are fun. These drama professors invited me to take part in a drama workshop about communication. And I said, yeah, sure, well, okay, not feeling very safe about it, but I went along, big room in the Department of Drama in the university, and they came in and they started doing various exercises and deep breathing and going into the corner. And all this stuff's going on for ages. I was doing my emails. And they stopped after a bit and said, we're ready. I said, good, so should we start? They said, yes. They said, are you ready? I said, sure. And then they said, so what do you do before you see patients? How do you prepare yourself before you see a patient? I said, well, I'm usually on the telephone in one hand, and I've got a sandwich in the other hand, and I rush into the clinic and sit down and ask to see the first patient. And they looked at me in complete astonishment. They said, do doctors do that? Do they not prepare themselves before they go on stage? Are they not in the right frame of mind before they see a patient? They were genuinely astonished. That was shortly before I gave up clinical work, and it changed my practice. I took time before I saw patients then, and I think it probably made a difference. We should also pay attention to the space. So I don't really know how to do that, but give it some thought. Is it a space that people are able to feel safe and comfortable in or not? And then try to validate the patient's experience and avoid negative words. Don't say it's probably not cancer. Don't say that. Don't say it's not something. Negative words are extraordinarily powerful and invalidating. So it's getting the language right, and it's just being prepared to be with another person, to accept their suffering as a reality, and to try to understand them for whoever they are. That sounds simple, I think it's extremely difficult, but I think if we could do that, our patients would get better without us having to wield the knife or prescribe the tablet as often as we do. Thank you for staying and for listening. And again, thank you for having me.
We have time for some final questions or comments. I have one comment to make, which is that after all this, I think as surgeons we keep very clearly in mind that some of our procedures we know not to work, and if we use them just because of the placebo effects, because the patient gets better despite the surgery being ineffective or inefficacious, we are going the domain of homeopaths and similar healers, which we try to not to be. Surgery is associated with harms, and operating on somebody is also putting them at risk and basically beating them up for a while and hoping they'll get better. So don't use the placebo as the only component of surgery. And second comment I have is that Bernard Russell has said somewhere that the whole problem with the world is that fools and fanatics are always so certain of themselves, and the wiser people are full of doubts. So I hope that each one of us is now full of doubts after this.
Thank you for excellent presentations. I'm interested in how long does the placebo effect last? Because we are measuring our results usually about 2 years after the surgery.
Yes, that's a really good question, and I don't completely know the answer. I'm fairly certain that it can last at least 2 years. That's based on one study I did myself, a drug study in a randomized trial over 2 years with placebo some years ago, and we certainly got placebo to last the 2 years. I think in some circumstances it can last forever. So if you get the sort of change that my case report of the physician got of a complete change in meaning and understanding, then I think you can have an effect that maybe lasts forever. So certainly it can be quite prolonged. Having said that, certain responses are short-lasting. So there's no clear answer. It can be a long time, it can possibly be forever, but some responses are relatively short. Again, it's context dependent, it's what sort of a thing you're talking about, related to expectations, beliefs, all that complexity.
Thank you.
Thank you for this great afternoon. I'm wondering, has this subject been brought up with children? Is the placebo effect same, greater, or less with children? Is there any evidence or your own opinion about that?
Yeah, that's another great question. I have to tell you I don't really know, because I'm, to my shame, my daughter would be appalled at this, I don't really know the literature. What I do know is that there is much less evidence, because trials in children are much less frequently done, and placebo-controlled trials, real difficulties with the ethics of that in children, so that we have much less data. So I don't really know. Having said all that, placebo works on animals, and you're going to have trouble with this, but I'm going to say it anyway. It even works on plants. So, well, good intention works on plants. So, so if it can work, if those effects can work on animals and plants, I'm sure they can work on children.
Personally, I'm convinced that putting a plaster on a child's injured bit is quite a strong placebo treatment.
Non-verbal communication, that is quite a lot, a big part of communication that you do. Is it something, you didn't talk about it that much, but is it something that even orthopedic surgeons can train?
Even orthopedic surgeons? Well, I'm not sure, really. Most others, but sure. Yes, I mean some of that again is quite simple. I mean, forgive me, but you don't face your patients like this in a buttoned-up, defensive way. You need to be open in your body position. You need to look them in the eye. The most important thing is eye contact. And I see a lot of people, well, I don't see them as patients anymore, but I still talk to people sometimes. We're all patients, aren't we? But complaining about the medical profession, and usually they say, he didn't listen to me. And you probe what that means, and they'll say something like, well, he was just looking at the computer screen, didn't even look at me. And actually looking at people and contacting them through eye contact, I think that's absolutely the most important thing. And again, I'm going to say something that's really difficult on a Friday afternoon. It sort of goes along with plants getting better from placebo, but we do make connections in ways that are not understood by our sort of materialistic view and understanding of the world. There is a connectivity that you sometimes experience when you're with a patient. It's a phenomenon that one of my colleagues and friends describes as the point when the room disappears, when there's just you and the other person, when you're making real contact. If you can achieve that, you are doing brilliantly, and that requires eye contact.
Okay, yes, thank you.
Just an add-on to that, there are some experiments on body language and non-verbal communication on the Nocebo, that if doctors, when they think that they don't have a painkiller in an experiment where the three arms are placebo, painkiller, and an antagonist. And if they think that they don't have the painkiller available, but they're forbidden to tell the patient that, the patients are worse than if the doctors think that they are giving any of the three, which is quite amazing.
Yeah. Thank you. Yeah, that's right.